you hear a nurse called Delia Spinelli giving a presentation on the subject of frailty. You now have 90 seconds to read questions 37 to 42.
Hi, I'm Delia Spinelli, and my presentation is about frailty. First of all, I'll define exactly what the term means. Frailty can be described as a syndrome characterised by a loss of reserves of energy that impacts both physical ability and cognition. It's a condition that affects around 10% of the over 65 age group, and that percentage increases with age. There's also an association with levels of socio-economic deprivation and with a range of comorbidities. With increasing age, frailty becomes more common, and 25% of people in the over 85 age group are affected. Having said that, it would be a mistake to view frailty as an inevitable consequence of old age. Whilst it is related to the factors associated with chronological ageing, it's also different to and occurs independently of the normal ageing process. This is important because if health professionals are familiar with the condition, then appropriate treatments can be in place and any risk of unintentional harm can be avoided. For example, it's often wrongly assumed that interventions and treatments suitable for non-frail people will also be appropriate for those with frailty. This may be because treatment guidelines are often derived from clinical trials that fail to take frailty into account. But the biochemical and physiological changes associated with the development of the condition mean that these patients respond differently to external stimuli, like infections and medications. Blood pressure control is an example of where inappropriate treatment may be administered to patients with frailty. So, as health professionals, we need to tailor our interventions accordingly, rather than simply treating these patients as older adults. We decided to set up a frailty nursing service in our area because we realised that frailty can manifest in a range of guises. Patients may experience falls, incontinence, weight loss, or cognitive decline. Crucially, these patients are often at greater risk of needing acute hospital care because they're less able to cope with adverse events. Once in hospital, the process of physiological decline can actually advance, often leading to loss of independence and transfer to long-term care facilities. Early care interventions can delay such negative outcomes, however. In other words, those adverse events can sometimes be prevented by early detection of frailty, holistic care, and what I like to call home-first management. So our frailty nursing service represents an alternative to traditional reactive models of care. Our first task was to identify patients at risk of developing the syndrome. Rather than waiting for primary care staff to spread the word, we decided to get in touch with all patients reaching the age of 65 and offer a face-to-face assessment. As well as including extensive geriatric assessments based on standard measures of functional, social, psychological and medical needs, the team used a holistic care model to identify those at risk of frailty. We then followed up with what matters most conversations with at-risk patients, that then formed the basis of a patient-centred care plan, allowing them to feel heard and involved in their care. When we initially proposed this proactive case-finding model, it raised concerns amongst local primary care physicians who feared it would simply increase demand for their own stretched services, and that was something nobody wanted. It was therefore essential for us to demonstrate how the service would not only improve care, but actually take pressure off them. So we visited all the local practices to provide information about our aims and methods. This actually paved the way for our specialist frailty nurses to open a dialogue that made it easier for them to begin supporting doctors by reviewing care plans and improving nursing care for patients. We also linked with other health and social care services to ensure a multidisciplinary response, with the aim of avoiding deterioration and the need to respond to a crisis. So the project was a success. Feedback was gathered via electronic surveys, nursing activity audits, and patient stories. These consistently showed enhanced patient well-being and satisfaction thanks to the service. The team now aims to gather enough positive patient outcomes to help us secure long-term funding for the service and possibly extend it to other areas. And this is part of a wider picture that's very encouraging. It's been suggested that frailty should be considered both a long-term health condition and a clinical speciality, and things are moving in that direction. This would bring the benefit of better coordinated care of frail populations. For example, specialist interdisciplinary teams could set up research programmes with a view to developing a set of standard practices that aim to reduce the need for hospitalisations for this patient group. Frailty finally seems to be getting the attention it deserves. So I'm going to